Apologies, folks, as I'm just going live. Again, Mir, Sandeep, Marta, Kranti, Betsy, Anam, Abdul Qadir, great to have you here. Just give me 2 seconds. I'm just going to go live on YouTube because I need to, because some of my followers and stuff will be there. And let me put this on mute. Apologies, folks. There we go. It's on mute. Okay, good. We are now officially live. Right. Okay. So welcome, everybody. I think I'm going to put this on record. So if any of you have any objections with this being on record, then let me know. But unfortunately, there's not much that I'm going to be able to do. You'll just have to leave the session. So it is going to be on record, and we start now. There we go. It's being recorded. And I love this transcript. So I've just got this transcript on here. So this should make it easier for those of you who just want to have a quick read. And first of all, I welcome everyone for absolutely taking the time out to be here. Abdul Qadir, Anam, Betsy, Unis, Georgia, Kranti, Lena, Marta, Mir, Sandeep. And I know as we work through this webinar, more and more are going to join. Look, we've already got members coming through. Great to have you here, Usha. Everyone, just, it's great. We have Amina, we have Abdul Qadir. It's going to be fantastic. And the names are going to increase. But before we get into the webinar, number one, I want to just thank God for giving us the opportunity to be here, to be safe, and really want to essentially pray for all those people who are in Ukraine, in Russia, or whatever you might be, not just in those parts of the world, but, there's a lot of people who are suffering. It's not just Ukraine. It's not just Russia. There's Kashmir, there's Palestine, there's many places out there in the world that people are struggling. So we mustn't forget that if it's not in the news, it doesn't mean it doesn't exist. So, we pray for those of you who are struggling, not in good health. So, I just want to thank God for giving us the opportunity, and we thank everyone who, and we thank God for making sure that we're safe. So, cherish the time that you have, cherish your health, make the most of it. And I welcome Muhammad for being here today. It's going to be fantastic. Me and Muhammad are going to be delivering this webinar to you, which I'm super duper excited about. Now, before we go any further, number one, so this is the link. I'm going to stop this. I'm just going to stop the share and actually put this in the link because let me just stop this share. And right. Okay, so I just made a boo-boo. Right, okay. So I need to put this link on the chat because a lot of students keep asking me that I missed your previous webinar. Can I have the recording of the webinar? So here you go. So let's get this out of the way first. So if I go to chat, and then I put it on to all panelists and attendees, here we are. I think it's gone. Did you receive that? Did you guys get that message? I think you did. I think you did. I think you did receive that. Fingers crossed. Oh no, it didn't go. Why? Send. Not received, right. It's not allowing me to. Okay, there you go. You got it now. Perfect. Right. Okay. That's the first thing out of the way. Number two, my internet has been playing up a bit, so I do apologize. It can be quite annoying. So I'm so sorry if it kind of just decides to just stop. I will definitely come back. If not, then I'm going to give these great opportunity for Muhammad to take over. So I'm very sorry, Muhammad, if I kind of drag you in there, but that's another kind of piece of thing that just keep in mind. Abdul Qadir, Adam, Amina, Anam, Asad, Asima, Bernard, Betsy, Christian, Darshan, Eunice, Jillian, Georgia, Huda, Khalid, Kranti, Lena, Lydia, Marta, Melanie, Mir, Pretty, Rohit, Rushida, Robina. Okay, the list is getting longer and longer as we speak. But right, why is this even relevant? So I get a lot of students asking me, Fahim, I don't get it. Like, why are you going through it in this way? Why don't you just get to the point and get through and get to hypertension, get to atrial fibrillation, get to diabetes? Why are you going through anatomy and physiology first? Why? Okay, let me explain this. Number one, let's quickly talk about blood pressure, right? Because that's what a lot of you have been asking about. And if I talk about blood pressure, we can define blood pressure as cardiac output times the total peripheral resistance. Now, in order for you to understand this, you have to understand how the heart regulates blood pressure first. If you don't understand how the heart regulates blood pressure, you are absolutely not going to be able to understand this fundamental formula which helps you easily manage hypertension, whether it's in a community pharmacy or it's going to be in a general practice and so on. Because if you don't know what cardiac output is, and you don't know what total peripheral resistance is, you can't manage this. While I'm writing this, someone define what is total peripheral resistance. Who knows what total peripheral resistance is? As I define this, someone tell me, what is total peripheral resistance? Who can tell me this? Put it in the chat. And don't copy it from Google. Literally try to put it in your words, okay? Who knows what's total peripheral resistance? Anybody who has an idea of what is total peripheral resistance? Who can tell me? Who can tell me what is total peripheral resistance? Any ideas? Come on, I know you guys know this. You guys have heard these terms. It's not like Darshan, come on, talk to me. Hiba, talk to me. Someone tell me, someone quickly just tell me exactly what did this mean before we get into too much depth. Okay, so some people have written something on there. I've got a feeling Usha would have definitely written something. I don't know why. I just know it. I just know. And before I write this up, the last one is contractility. Right. Okay, here we go. So who's got some answers? So somebody has put down, I knew it, Usha. I had a feeling. Anyway, it says, so somebody has put down, anything that makes the heart work harder, resistance from the arteries. Okay, Khalid, kind of. Resistance from arteries and veins, Betsy, kind of. Anything that can cause an obstruction, okay. Resistance from the blood vessels, force exerted by vasculature. So all of you have a concept of it, but we've got to clear that concept. It's not 100% correct. And I'm going to explain that to you as we start getting into this in a lot more depth. But look at this. Okay, I've got another question for you. Any of you tell me, someone tell me while we're talking, in this formula here, out of cardiac output and the total peripheral resistance, which one of these absolutely will alter systolic blood pressure? Let me repeat the question. If you're managing someone's diabetes, if you're managing someone's hypertension, the person comes in, he has a blood pressure of 150 millimeters of mercury, and his diastolic is this. This is hypothetical. If you wanted to lower his blood pressure, or you want to lower his systolic, which one do you have to alter? So Khalid's put down cardiac output. If you don't agree with him, raise your hands. If you don't agree with him, anybody else who agrees or disagrees with Khalid? Khalid goes that in order to alter systolic blood pressure, the focus is going to be on cardiac output. Anybody have any ideas? There's 40 plus people here today, from Melanie to Muhammad to who else who agrees with him? So Kranti goes, Betsy goes, okay, both. Mir says both. Interesting. Fair enough. Right, Khalid, now I'm going to put you on the spot. Can you explain to me, I'm going to give you the chance to talk. Can you explain to me why you went with, why systolic? Go on, Khalid. Explain to me why systolic. Can you explain this?
Can you hear me?
I can absolutely hear you, my friend. How are you? Assalamu alaikum, bro. You okay?
Yeah, wa alaikum salam. I'm good, thank you. Yeah, my understanding is that the systolic is basically when the heart is contracting, and the diastolic is when it's relaxing. So the rationale behind the answer was that, you know, cardiac output is during the contraction, so that's why I chose that answer.
Okay, you're well done, and absolutely thank you for sharing that answer. You're kind of on the right tracks. You're definitely right, but you're kind of on the right track. Who else wants to give it a try? Hoda, do you want to give it a try? Explain to me how cardiac output is absolutely related to the systolic blood pressure. You can talk, you don't have to be shy. Usha, you want to give me an answer, Usha? Can I pick on you, Usha? I feel like picking on you. I don't know. Usha, come on, tell me. Is cardiac output, and why is cardiac output directly related to systolic blood pressure?
I think from what I have seen is, if the cardiac output falls, then the systolic blood pressure automatically falls.
Okay.
So I feel that the amount of, I mean, both of it has got related, the cardiac output and the total peripheral resistance. But if there is less blood coming out of the heart, then that would automatically affect the systolic.
Okay.
Systolic blood pressure.
You are right. You're not wrong. Absolutely right. So thank you for your answer. There's nothing wrong what you've said. It's correct. But I want to make these, thank you, Husha, I want to make these concepts even more clear to you. And in order to clarify these concepts, you have to have a basic understanding of the heart works. You have to absolutely know that preload, or this term, what is preload? What is afterload? What about contractility? What about the heart rate? What about stroke volume? What about cardiac output? What about total peripheral resistance? End organ damage. When we talk about end organ damage, and we say, oh, this person has end organ damage, what organs are we talking about? All of this has to make absolutely clear sense to you for you to be able to safely manage, diagnose, and treat hypertension. In order to do that, you have to understand how the heart regulates blood pressure first. If you don't understand how the heart regulates blood pressure, you can't manage blood pressure. You're going to be working in your general practice. You're going to be working in community pharmacy. You're going to have people having this high blood pressure, and you're going to think, what do I do? Why do we request an ECG? Why do we request bloods? Why is the kidneys involved? What's the difference in a stroke, a transient ischemic attack? What are all these terms meaning? This is my point. There's no point learning stuff which doesn't make sense. Once you nail this, it becomes easier. That's why we're building this series first, so all of this makes sense. And then, boy, oh boy, this gets even further. Just have a look at this puppy right here. This puppy right here. Things get even more exciting when we start talking about heart sounds. We start talking about extra heart sounds. We start talking about S1, S2, S3, S4. We talk about clicks, we talk about snaps. It's going to be absolutely beautiful. But first, you've got to get the basics. You can't get into the position that Mohammed is in or that I'm in without nailing your fundamentals. And if I said to you, what is cardiac output? Absolutely, you should be able to say it. Total peripheral resistance, there should be no confusion between, oh, I think it's the veins, the arteries. No, you should know that it's the arterioles. It's those arterioles that will have a big difference on the resistance to blood flow. You should be able to define what is hypertension and blood pressure. So this is why basics first, and then everything becomes easy. So that's why I wanted to put it into perspective, and that's what we're working towards. Be patient, and it will all make sense to you. And just have a look at this diagram here. Look at the knowledge that you're about to have. So keep that in mind, what we're going to go through. In our previous video, and again, examining the heart, you're going to know about JVP. You're going to understand about bruits. You're going to understand how pulses work, inspection. It's going to be absolutely fantastic as we start to work through this, and you're going to really, really love it. So this is why I wanted to put this into perspective. I know some of you are like, oh, hey, teach me about hypertension. Look, if you don't understand your basics, you don't understand hypertension. You can read textbooks all you want. If you don't understand your basics, mate, you don't understand hypertension. Once you understand your basics, everything becomes a lot easier. And again, when we talk about heart sounds and we talk about the examination, it becomes good. So in our previous lecture, we went through the heart itself and discussed the heart walls. We did that. So I want you guys to watch that webinar. Again, for those of you who are coming late, naughty, you should be on time. But here is the link for those of you who missed the webinar last time to watch it first, so we don't end up going backwards. And now we can start our webinar itself. And Mohammed, if I could kindly ask you to, I guess, unmute yourself. Here we go. And we can start. So sorry, before you start, Mohammed, for those of you who don't know Mohammed is a final year medical student, technically or about to become a doctor, a mentor of mine, someone who I have learned so much from. We are very privileged to have him here. So thank you for giving this opportunity, Mohammed, to be here. And Mohammed, when you're ready, do you want to start off with this slide, or do you want to move on to the next slide?
First of all, hello, and thank you for everyone to come here at this time. I just want to say one thing that, in this world where a lot of people are easily learning how to take a life, it's very important for us to put some effort to learn how to save lives, which we are needing at this moment in these hours. But I would first like to go to the next slide and just a little bit talk about the question you asked about the hypertension and the cardiac output and total peripheral resistance. Just to give a very short answer is that it's not like nothing in body is so simple that you say that, one or the other. It's both of them. always, that's the reason why whenever someone has a high or like, you know, even mild hypertension, we always ask to do a blood test, a complete blood test, so that we can see exactly what is causing or, you know, what is happening. So it's always both. You can't just, you know, control one and expect the other one to just disappear. It's just both. You have to consider both of them. But at the topic at hand, tonight we would like to talk about the anatomy of the heart a little bit. And it is very important to know and have ideas about the anatomy of the heart for multiple reasons, because a lot of common and fatal diseases that we face in daily life in hospitals are associated with heart. For example, heart attacks or stenosis, or all of these things are related. And the most important part to understand of the anatomy of the heart is that it is simply made up of 4 chambers. And do you have the picture of the chambers so that you can actually, it would be easier to, yes, perfect. So the heart is made up of 4 chambers, and it is divided into right and left side by something called interventricular septum. You really don't need to learn that much about the names, but just understand that it's divided into 4 chambers, right and left. And in the right side, we have right atrium and right ventricle, and on the left side, left atrium and left ventricle. And it's important to know all of these things. Firstly, is because when there is, for example, a heart attack or myocardiac infarction, a lot of these, sometimes maybe these chambers become like they die because the blood is not reaching to them, and due to the heart attack, these walls of the chambers die and they are unable to function. This is one of the reasons why we need to know what are these and what are their function. I would like to start with how the blood basically flows through these chambers, and after that we go through the rest of the topics. The easiest way to start this is that we consider the blood that is low on oxygen concentration coming from the vena cavas, from the rest of the body, to the right atrium. And this right atrium is connected to the right ventricle through an opening known as tricuspid valve. So we go to the valves a little bit later on, but just understand that valves are very important for the function of the heart. The reason for that is that you don't want, when the heart is contracting, you don't want the blood from the chambers go to the atriums, because the purpose of the chambers and the ventricles is that you want to push the blood away from the heart, outside of the heart, not, you know, into the heart itself. You don't want it to circulate around the heart. That would be dangerous. So these valves basically prevents the backflow of the blood. So when the blood arrives to the heart at the right atrium and then goes to the right ventricle, the ventricle then contracts and travels to the lungs. This is known as pulmonary circulation. Over there, the blood obviously gets oxygenated and all of those things, and it then comes back to the left atrium and again travels through an opening known as mitral valve and goes to left ventricle. Now again, the function of the valve is the same as the tricuspid valve, prevents the backflow of the blood. And then the left ventricle contracts and pushes the blood out of the heart to the rest of the body. And this is known as systemic circulation. Now, if you pay attention, over here, the left ventricle, the walls of the left ventricle is much thicker as compared to the right ventricle. Does anyone know the real reason for that? If anyone has any idea or anything.
Anyone? Yeah, go on. Go for it, Khalid. Write it in the chat, or anybody can raise their hands. Who's raising their hands? We've got 3 people. Amina, go on. You can talk, my dear. Why is the left ventricle thicker then? Amina, my dear, if you want to speak, if you're shy, you don't have to speak. It's cool. I can understand. Oh, no, you're not shy. Go right.
No, I just read. No, the left ventricle is more thicker because it has to push blood all around the body, whereas the right ventricle only pushes it towards the lungs.
Fantastic.
Yeah, you are absolutely right. And it is very important to be able to push everything. Because if you have paid attention, I don't know if you have seen a patient with a heart failure or anything, usually their extremities are very cold, colder than the rest of their body, and a little bit bluish. That's because the heart, and especially the left ventricle, has lost its ability to pump efficiently. So the function of the left ventricle is the most important for us. Obviously, the rest of the ventricles and the rest of the chambers are also very important, but left ventricle is the main thing because the rest of the body is being supplied with it. And obviously, like the other things I would like to mention is the vessels around, like the arteries and the veins around the heart. The blood that I mentioned that is coming from the rest of the body to the right atrium is coming through a series of veins known as vena cavas. We have superior vena cava and inferior vena cava. Again, these veins are commonly used for a lot of different practices that we have. So it is important to know them. And the blood, the oxygenated blood from the lungs come through the through the vein known as pulmonary vein through the left atrium. And the most important basically artery in the body is the aortic artery. And it's the important one because, and it is the thickest arteries that we have in the body naturally. So because it needs to withstand so much pressure, because obviously we mentioned that the thickness of the left ventricle is so thick that it has to push with a lot of force. So obviously the artery has to withstand that much of a pressure. And I forgot to mention as well that the right side, when the right ventricle contracts, it pushes through the pulmonary arteries. Now, can anyone tell me why we call the pulmonary artery an artery? Because it's containing the relatively low oxygenated blood, and the blood that is coming from the lungs that is obviously more oxygenated, we call it a vein. Does anyone have an idea for that? We mentioned this in the last class.
So yeah, anybody have any idea? Amina is definitely on it. Somebody else who's going to get a chance to speak. Hoda, my dear, go on. Explain why the pulmonary artery is called an artery when it's going kind of, why do we call it an artery? And explain that. Any reason why? Any ideas? Hoda is not speaking. Anybody who can speak? Abdul Qadir has given an answer. Usha's hungry to give an answer. Usha, go and explain it.
Is it because it takes blood straight from the heart into the lungs? So it's coming from the heart into the lungs. So it's called an artery.
Yes, you are correct. And one of the easier way to understand it is that arteries are always carrying the blood away from the heart, as you mentioned. And veins carry the blood towards the heart. So that's one of the ways to know. The other things I want to mention is that the other two important valves in the heart are the pulmonary valve and aortic valve. Obviously, I think you must have heard about a lot of elder people have aortic stenosis, meaning that the valve that is preventing the backflow of the blood from the aorta into the left ventricle, it has basically narrowed. And this is one of the problems that we face, especially when we age, is that this narrowing of the valve creates a lot of problem. It's most of the patients present with fainting and all of those things, or like the extremities are very cold and the blood pressure varies between both hands and everything. That's one of the signs of the aortic stenosis. So again, I'm giving example by each topic that we go by, so that you understand that all of these things that we are teaching from the anatomy, although when I was a student in the levels that I had to study anatomy, I found it very boring, but now that I look back, it's very important. All of these things have a reason. Another example is that the mitral valve, a lot of you must have heard that there is regurgitation, or again, a stenosis of mitral valve, or prolapse. A lot of people have it. Like, I would like to distinguish between stenosis and regurgitation. Stenosis is the narrowing of the valves, not necessarily the aortic or the mitral. All of these four valves that we mentioned basically can get either narrowed, or they can be opened up and regurgitation can happen. So stenosis means narrowing of these valves. Obviously, when it narrows, not so much blood is going to be able to get passed through it, and heart has to pump much harder to basically pump the blood out or through these valves. On the other hand, when we say there is a regurgitation, means that the blood is, like, the valve is not performing its function, which is prevents backflow. So when, for example, if you consider mitral valve regurgitation, when the left valve, when the left ventricle contracts, some blood will flow back into the left atrium. These problems, for example, if you consider mitral regurgitation, over time, it can lead to pulmonary hypertension. The lungs will be filled with water, and there will be a lot of problems. And ultimately, if you don't treat it on time, it can lead to heart failure, all type of stenosis and regurgitations. I think that is, we have covered all the heart chambers. Oh, I forgot to mention one important thing, is that Fahim, if you have a slide to show the aortic valve and the anatomy of the aorta.
I'm just going to take a picture of this slide, and I will show the right. I'll leave the stuff on the aortic valve. I don't know if we've got something for the aortic valve. I don't think so. I didn't specifically have a slide for that. Maybe here.
Go to the next one. I saw that there was few.
I think here there is the aortic valve here, which we've kind of this one, but it's not the best.
No, go to the previous one that you showed.
Okay, I can do that for you, and I've purposely left the drawings on there because I don't know. Back.
Yes,
back.
this one. No.
This one more.
No, the other one that showed the.
That was the cardiac skeleton, and it won't be here, will it?
No, you're going back. Go forward.
Forward, 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 forward. Here, there's the aortic valve.
Next one, go forward.
Next one, and then we end up here.
Yes, this one. One of the other important things about the anatomy of the heart, obviously, is the blood vessels that supply the heart. Obviously, like, we don't expect like you guys to know all the names of it, but understand one of the important things is that If you look at the aorta over there, at the base of the aorta, there are two main branches of the vessels that are being basically, they originate from the base of the aorta and supply the heart. It is very important to know that, because these vessels are the vessels that get obstructed and lead to myocardiac infarction. And again, in the next class, I think we are going to discuss about ECG and all of those things and MI, that, you know, the process that we have for myocardiac infarction is so precise that, you know, experienced cardiologists can tell you exactly where the infarction is by just looking at the ECG of the patient. So again, it is important to know the anatomy of the heart. One more thing I wanted to mention is that in the case of aortic stenosis, the patient will experience some chest pain as well. The reason for that is that because there is basically less percentage of the blood that is required to be pumped out through the aortic valve, less blood will also flow through those vessels that supply to the heart. So obviously there will be pain in the heart and chest. I think that's all it for now for the anatomy of the heart.
Perfect. I'm just going to just to summarize what we've just spoken about, because some of this can get quite challenging and be difficult. And I want to volunteer to help me kind of really explain what Muhammad has just said in words. Who's brave enough to actually go through with me and really all of us together learn exactly how the heart, or rather the blood flows through the heart? Who's brave enough to go through the entire steps and really go through step by step exactly how blood enters which chambers, which valves open, which valves close, so you can all take a screenshot of this and remember it for life? Who's brave enough to go through this? Who wants to do it? We've got Zara, we've got Sandeep, we've got Soon, Shahida, Sarah, Rabina. Sarah, oh, hello, Sarah, how are you? Ricardo, Omnia, Nimish, Muhammad, Mir, Melanie, Marta. Who's brave enough? Who wants to go through it? Who wants to go through it? Let's have a look. Who's saying that they want to go through it? I'll have a go. Khalid, I will give you a chance in a second. Anybody else? Anybody else who wants to go through step by step so we can all learn exactly how blood enters from start to finish? And which valves open, which valves close? Who wants to go through it? Khalid has volunteered. Hoda, did you get a chance to speak? I don't know. I'm gonna unmute you, give you a chance if you'd like to do it. Hoda,
no, I didn't get a chance. No, I would say I was away.
Oh, would you like to speak now? Do you want to give it a chance and go through it?
Yeah, okay. Yeah.
Okay. From start
Okay,
to finish, let me write it down as you speak. So I'll do the first line and I'll write down blood enters the right atrium. Okay, now blood is sat in the right atrium. What's going to happen next?
From through the inferior vena cava, it enters the right atria. The tricuspid valve opens.
Okay, let me write this down then. Tricuspid valve opens.
Okay. To let the blood in. And then it closes afterwards.
Okay, 1 second, slow down. So the tricuspid valve opens, and at the same time, the mitral valve will open.
Yeah.
Open, perfect, that's fine. So then blood enters which chamber?
The blood enter lungs.
No, right ventricle. Blood enters the right ventricle.
Right ventricle.
Left ventricle.
Into the lungs.
No. Before that happens, you've got to go through everything, the steps, not that fast.
Okay.
What happens next?
Right ventricle. Then you get the aortic valve. No, not the aortic, sorry. The mitral valve is open. The blood goes through the arteries.
No. Okay.
No, sorry.
Who wants to help Hoda? Who wants to give it a chance? Amina? Hoda, thank you for that. Let's give somebody else a chance.
Thanks, sorry.
Thank you. Amina, go on, my dear. Explain to me. We've got to part number 3. So
Okay, so
where are we next? What's going to
so
happen?
the
Go on.
blood's gone from the right atrium to the right ventricle.
Well done.
And then the blood has to go into the pulmonary
Yeah.
vein, not vein, artery into the lungs.
Yeah. What has to happen for that to happen? Which chambers have to open? Which valves have to close? What has to happen?
I can't see, my picture's too small.
Sorry?
Right. Sorry, I'm just enlarging my picture. So you've got the tricuspid valve that's shut. So when the blood goes from the atrium to the ventricle, it shuts, so there's no backflow. And then
So what has to close then? Let's write it down. What has to close?
you need the tricuspid valve to close.
Yes, tricuspid valve closes and mitral valve closes. Which heart sound do we get? This is the first heart sound.
Lub.
Yes, this is the first heart sound. So everybody really pay attention to the first heart sound. This is our first heart sound. This is important for you to remember. You have to understand this, that this is when you get the first heart sound. So first blood entered the right atrium, tricuspid valves, mitral valves open, no heart sounds. Like when a door opens, you get no sound. It's only when the door closes, you get a sound. Blood enters the right atrium, blood enters the right ventricle, left ventricle. Then the pressure builds up in the ventricles and blood tries to go backwards. So you can imagine all this pressure building up. Blood says, right, I'm going to try to go backwards this way. And as it tries to go backwards, boom, valves close. Tricuspid valve close, mitral valve close, and that is the first heart sound. So if I said to you, what is S1? All of you should know as of today, S1 is made up of 2 components. S1 is made up of 2 components. Tricuspid and mitral. Okay, go on then. Amina, what happens next?
It then travels up the pulmonary valve, pulmonary vein, and the pulmonary valve opens.
Okay, so pulmonary valve and aortic valve open. Do we get a sound?
I can't remember.
Okay, so as I said to you, when the door opens, you don't get a sound, do you?
No.
It's only when it closes. So when the valves open, no sound. No sound.
And when it goes up, when it closes, the dub sound, that's the second sound. And the blood will then travel through the pulmonary, because it's deoxygenated blood at this point. It's going to go to the pulmonary, it's going to go to the lungs, and it's going to get rid of carbon dioxide into the alveoli and pick up the oxygen. So now the oxygenated blood is going to come back down and come into, how is it now? Pulmonary artery vein, where the blood will then enter into the right atrium.
So the blood will then enter
left atrium, so left atrium. And then the valves,
left ventricle, and then the valves close, like you said. Then again, we're going to have those valves
pushing the blood into the left ventricle.
Yeah.
And then the blood will get pushed at high pressure out into the aortic arch, and out into the rest of the body.
Yeah, I'm just going to write this down. Pressure increases, pressure decreases. Pressure decreases in left ventricle, So aortic valve closes, therefore second heart sound. Okay, so everyone understand this, and let me maybe close your eyes, just imagine this. Let me actually tidy up this picture to really make a bit more sense to you guys, because you've got to get this, and I'm sure Muhammad will agree that if you get this part right, it will become a lot more easier for you guys to get this. And I think we will leave it at this today, because it's quite a lot of information for you guys to understand. But if you can go away with the heart like this and really understand it, you guys will be absolutely amazing, and it'd be great. So let me break this down for you, because I know it's getting quite late. It's now, I don't like to do more than 40 minutes because I know some of you guys get really tired. Okay, so look what's happening here. Blood enters here. Let me delete this. This is annoying. I just need you guys to understand this. Right, okay. So blood's going to enter here. This valve and this valve, okay, this is the tricuspid and mitral. Blood enters the left atrium and right atrium. Blood goes into the left ventricle and right ventricle, valves open, no sound. Blood then tries to go backwards like this and like this. Obviously, whatever happening on the right side is happening on the left side. And then your aortic, then your tricuspid and mitral valves close. Tricuspid and mitral valves close. Here. That's your first heart sound. Now we're in phase 2. Now you can imagine, moving backwards actually, now you can imagine that the blood is kind of stuck here now. Here it is, the blood is stuck. We have now blocked this off here and here. The blood can only go one direction, and it goes to the pulmonary arteries and it goes to the aortic arteries. And then these valves open. This is the pulmonary valve and this is the aortic valve. When valves open, no sound, okay? Blood then rushes through. So blood will rush through from this side and end up into the left atrium, into the left ventricle. And in this case, blood will keep moving forward. And now what happens is that as the pressure increases, as the pressure starts to increase in the left ventricle, the blood will go through the aorta. And then you know what happens after that? The pressure in the ventricles decreases. And as the pressure in the ventricles decreases, blood tries to flow backwards and then the vessels go shut. So as a minimum, without confusing you, and we will go through this in a lot more depth, just understand two basic things. If I said to you, what is the first heart sound? You should all say, hey, Fahim, that's pretty straightforward. The first heart sound is the mitral and the tricuspid valve closing. That's it. Perfect. If I said to you, what is the second heart sound? You should say, hey, Fahim, really easy peasy. That is the aortic and pulmonary valve closing. That's it. If you understand this today, you have learned a lot, because this can be very, very confusing, and a lot of students get confused by this. And if you get confused by this, it starts to become really tricky for you to understand heart sounds. It starts to get very tricky for you to understand examination. Just remember this. Just remember this. Now, at this point, I'm happy to take any questions that you have. Does anybody have any questions about this heart sound? Please tell me that all of you folks are going to walk away here. Zara, Tunalu, Sanita, Sandeep, Soon, Shama, Shahida, Sarah, Rabina, Rashida, Ricardo, Pretty, Pravina, Omnia, Nimesh, Natasha, Nabina, Muhammad, Mir, Melanie, Marta, Lena, Kranti, Jandika, Hanish, Georgia. There's 50 plus students here. Is there anybody who's like, I don't get it? Does S1, S2 sound different? They do sound slightly different, but for now, I just want you to understand, if I said to you S1, you should say for him, S1 is the closing of the mitral and tricuspid valve. If I said to you what is S2, it is the closing of the aortic and pulmonary valve. That's it. Don't worry about the heart sounds, because for those of you who want to learn heart sounds a bit more, for those of you who want to understand, we're going to go through the courses that we offer. I'll discuss that with you. You can attend them face-to-face. We'll go through that. Melanie's asked, where does the third heart sound come from? Don't confuse yourself right now. We'll go through that later on. Please don't confuse yourself right now into that. We'll go through that later on. Just understand the first and second heart sound. Any questions? Anybody here like confused? Okay, Fahim, I don't get it. I really don't understand what you're on about. You've absolutely confused me today. You've ruined my Friday night. Thank you very much. Any confusion? Any confusion? No, I think it's clear. Muhammad, I don't think please.
Just one thing, someone asked in the chat that does S1 and S2 sound they are different? Actually, not really. You can't just by putting the stethoscope on the patient and like hearing them, you cannot really distinguish which sound it is by just hearing them. It depends on two things that you can do to actually understand which sound it is, either by basically palpating the pulse, the central pulse of the patient, and when the pulse hits, that is the S1 sound. And the other way is by the way you like where your diaphragm of your stethoscope is on the chest of the patient. That can also help you out with that. But the S1 and S2 sounds are not different. by just their sound, but S3 and S4 are definitely different.
Mohammed, thank you for that. Right, is that clear? Because some of you might ask, hey, Fahim, how do I, how does it, there is an inferior vena cava on each side, on the right side. Yes, on the right side, we have an inferior vena cava and a superior vena cava. Hoda, you can see it here. Look, my dear, inferior and superior. I just want to add about what Mohammed was trying to explain to you. Khalid, you've got a question, go on, ask it. Khalid has a question for Mohammed.
Yes, can you guys hear me?
Yes, we can. Go on,
Yeah.
Khalid.
So just a quick question for Mohammed. Regarding the S1, S2 sounds, when you mentioned that we use pulse to assess when the S1 begins, are you on about the apical pulse on the apex of the heart, or any other peripheral pulse or carotid?
Perfectly, we do the carotid artery because it's easier. Because, for example, if you want to just straight up listening to the mitral valve itself, you have to place your stethoscope on the apex of the heart, so you can't both palpate and put your stethoscope over there. So usually we put the stethoscope on the apex of the heart and place the other hand for palpation on the carotid artery. Yeah, I hope that answered your question.
So
yeah, thank you for that.
Just to add that, this is how it works, and I don't want to confuse anybody too much, but imagine S1, S2, then you have the pulse, and then you have S1, S2. So can you see, if you can time the pulse, the next is going to be S1. Can you see this picture I've drawn? Khalid, can you see this?
Yeah, that's fantastic. Thank you.
So now you need to understand why the carotid, because if you were to palpate, like let's say the radial artery, it takes time for that pulse to appear. When you're at the carotid, which is close, it's very much in sync with when the heart beats. And I don't want to confuse anybody, so I don't want to get into this in depth, but if you've just got a question, hey, Fahim, how do I time the heart sounds? Because you are going to learn this in examination. That's how we do it. After the pulse, or in sync with the pulse, you've got the first heart sound. And there is a reason for that, but don't confuse yourself right now. If you just understand this much from today, that when the valves close, we get a sound. Opening of valves causing sound is pathological. It's not normal. Think of the door. When you open a door, the only time it makes a noise, if it's creaky, if it's not been oiled properly. Otherwise, no sound. Closing of heart sound, closing of valves causes a sound. And if you want to time it, get your hand, put it on the carotid, put a stethoscope. When you feel the pulse and you've got a sound at the same time, you can say it's the first heart sound. And now, just to clarify, I want to go back to this examination and show you something just before we call it a day. I want to show you something. And look, when we start to do examinations, can you see one of the things that you have to be able to examine, everyone, is S1 and S2. And then we go into a bit more deeper splitting of heart sound. So I've taught you something quite valuable, or rather Mohammed has today, and this is this. You've now got some theoretical understanding of this. So I'm happy to take questions if you have. I just want to address something because a lot of students ask me all the time about kind of Medlin and Medlin courses. And could you please tell us a bit about what you do if we want to improve ourselves clinically, blah, blah, blah. Here you go. So people keep getting in touch, and I don't always get the time to go through this. I'm teaching more than this. But anyway, look, for those of you who want to develop your clinical skills and just want access to all our video content, we have a course that's just for our video content. So it's just our video content where we go through all from diabetes to cholesterol to hypertension to minor illnesses, start to finish e-learning. For those of you who want access to face-to-face learning with our doctors, would like hands-on support, access to our face-to-face classes, live events, we have another course, and that's the 2 courses that we offer. So in general, if you said, Fahim, what is it you actually do? Number 1, we help pharmacists upskill. We help you develop your clinical skills. So you want to learn how to diagnose, manage, and treat asthma, diabetes, cholesterol, hypertension, ENT diseases, set up your clinics. We help you with that. You could do it on your own, just through our e-learning videos. That's here. You could do it through hands-on, face-to-face, where we actually teach you in our face-to-face classes with our doctors. We set you up with our clinical supporting tool that we've developed as well, where we can help you separately. We do all of that. And we'll leave that where my colleagues can get in touch with you to help you with this, for those of you who are interested. But that's all I wanted to say today. I want to thank Mohammed for giving us this opportunity to be here today, Mohammed. So thank you very much for the opportunity. It's been fantastic. Any of you have any questions regarding what we've discussed? Let me know. I'll stay for another couple of minutes. Any of you have any questions regarding our courses, get in touch. Otherwise, we will be in touch with you folks. And I wish you all a fantastic evening. Again, we pray for everybody in Russia, Ukraine, who's struggling with everything that's happening. But please, any questions, let me know. And thank you very much for being here this evening. And absolutely, God bless you all. So thank you very much. Khalid, thank you. Muhammad, again, bro, thanks for everything. Really appreciate it. You're fantastic as always. And yeah, thank you all. And I'm here for
no worries. Thank you everyone for coming here, and wish you all a very good weekend.
Thank you, Mohammed. Thank you. Anybody got any questions? Let me know. I am here for a bit. Anything you want to ask, please let me know. And otherwise, we'll see you guys in a couple of weeks' time. Asima, we had one previous session, and the recording for that is here if you've missed it, and I will put it here for you. The recording for that is here. There you go. Here we go. Yeah, Hoda, we do help with prescribing for those of you who are struggling to find a DMP. For those of you who are struggling, we can help you with all of that. Absolutely. We can organize the doctors for you. We can do the teaching. We can do the whole thing. So yeah, we can absolutely help you with that from start to finish. What course to go to, how to apply, the whole works. Tanula, you asked, how do I find out about your courses? My colleague will get in touch with you, and he will go through everything about the course and the packages that we offer. So my colleague Ricardo will get in touch with you. Ricardo will get in touch with you. So if we've got your contact number, which I think we should, then it should be easy to get hold of you. Otherwise, you could you could take my number. There's my number. Christina, hi. Can I speak with someone about DMP for prescribing course? Yes, my colleague Ricardo can get in touch with you. So Christina, Tanula, my colleague Ricardo will be going through everybody name by name. So certainly we will be helping any of you who've got questions and even general advice. Certainly my colleague will get in touch. So yeah, Christina, great. Tanula, great. We'll be in touch. For all of you who have Hoda, so that's fantastic. My colleague will get in touch with you guys. So yeah, Ricardo will be reaching out to you guys. For all of you who have help or need help, we'll be getting in touch with you. So yeah, thank you all. Thank you. Right, I'm going to go now. So thank you very much, and God bless you all. Have a wonderful evening, and thank you for being here today. Thank you. Oh, is there a link for the replay session? Yes, Lena, here. Here you go, here you go. The replay session is here, my dear. There you go. Alina, you've got my number anyway. If there's any problem, just text me directly.